Hello and welcome to our high-yield CCRN review on neurocritical care. If there's one area that separates a good critical care nurse from a great one, it's mastering the management of intracranial pressure and cerebral perfusion. Today, we're going to break down these complex topics into simple, testable concepts that you can use to ace the neuro questions on your exam. Let's get started. Everything we're about to discuss starts with one simple, unchangeable fact. The adult skull is a closed, rigid box. It cannot expand. Inside this box, there are only three things: brain tissue, which makes up about 80% of the volume, blood, which is about 10%, and cerebrospinal fluid, or CSF, which is the final 10%. This simple concept is the entire foundation for the Monro-Kellie Doctrine. The Monro-Kellie Doctrine is a simple rule of pressure and volume. It states that since the skull is a fixed box, if the volume of one of its components goes up, the volume of the other two must go down to compensate. For example, if a patient develops a brain bleed, the body's first response is to shunt CSF out of the skull and compress the veins to make room. But this compensation has a limit. When the body can no longer compensate, we hit a point of decompensation, and the intracranial pressure, or ICP, begins to rise very, very quickly. This is the danger zone for our patients. While a high ICP is the problem we're trying to fix, cerebral perfusion pressure, or CPP, is the value we are trying to protect. CPP is the single most important number you will manage in a neurocritical patient. CPP represents the pressure gradient that pushes blood and oxygen to the brain. If the CPP is too low, the brain becomes ischemic and starts to die. If it's too high, it can worsen cerebral edema. The normal ICP is between 5 and 15, but our goal for CPP is a very specific range, 60 to 70 millimeters of mercury. You must memorize that range. It's also important to note that while the normal ICP range is 5 to 15, interventions are normally not done unless the ICP range is at 20 or higher. Your goal with these neuro patients will be keeping their ICP less than 20. This is the formula you are guaranteed to see on the CCRN exam. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. Let's walk through an example. Your patient's blood pressure is 110/60 and their ICP is 22. First, you calculate the MAP, which comes out to 77. Then you apply the formula, CPP equals 77 minus 22, which gives you a CPP of 55. Is this good or bad? It's bad. It's below our goal of 60, which means this patient's brain is being underperfused. So if our CPP is low, how do we fix it? Looking at the formula, there are only two things we can do. First, we can increase the MAP. We do this with vasopressors, and the first-line agent in neurotrauma is norepinephrine or levofed. Second, and often more importantly, we can decrease the ICP. We do this through a series of tiered interventions. For the CCRN exam, most of the questions will focus on the interventions you will take to lower a patient's ICP. Let's start with Tier 1, which are the fundamental nursing interventions. First is positioning. You want the head of the bed elevated to 30 degrees to promote venous drainage from the brain. It's also critical to maintain a neutral head and neck alignment. Any twisting or flexion can kink the jugular veins and raise ICP next. We reduce stimuli and metabolic demand. This means clustering care, keeping the room quiet and dark, and providing excellent sedation and pain control. Finally, you must maintain normothermia. Fever is the enemy of the injured brain. It dramatically increases metabolic demand and ICP, so we treat it very aggressively. When those nursing interventions aren't enough, we move to Tier 2 osmotic therapy. The goal here is to pull fluid out of the swollen brain tissue. The classic drug is mannitol, an osmotic diuretic. It pulls fluid from the brain into the vasculature to be peed out by the kidneys. You have to watch for hypotension and dehydration with this one. The other major option, and often the preferred one, is hypertonic saline, usually 3%. This creates a powerful osmotic gradient that pulls water directly out of the brain cells. It's great for hypotensive patients, but you must have a central line, and you have to monitor their sodium levels very closely. We can also use an EVD to drain CSF directly. This will also allow you to have an accurate monitoring of the patient's ICP. This next slide is a critical warning. Cushing's triad is a very late and very ominous sign of extremely high ICP. It indicates that the brain is beginning to herniate or shift, which is a terminal event. You must know these three signs. First, a sudden and profound bradycardia. Second, hypertension with a widening pulse pressure, meaning the systolic goes way up while the diastolic stays put. And third, irregular respirations like Cheyne-Stokes. If you see this triad, your patient is actively dying. If you're interested in learning more about Cushing's triad, check out our video that's dedicated specifically to this and dives a little deeper into the triad itself. Okay, let's do a practice question. A patient with a TBI has a MAP of 80 and an ICP of 25. The nurse has already ensured proper positioning and sedation. Which of the following interventions is the nurse's priority? A. Administer a bolus of normal saline. B. Increase the norepinephrine to target a MAP of 90. C. Administer a dose of IV mannitol as ordered. Or D. Prepare for a decompressive craniectomy. Pause the video to think about your answer. The correct answer is C. Let's break it down. First, calculate the CPP. 80 minus 25 is 55, too low. Next, analyze the problem. Is the MAP too low or is the ICP too high? The MAP of 80 is perfectly adequate, but the ICP of 25 is dangerously high. Therefore, our priority must be to lower the ICP. Looking at the options, administering mannitol is the correct next-tier intervention to directly address the high ICP. Let's summarize the key points. First, remember the Monro-Kellie Doctrine. The skull is a closed box. Second, the formula is King CPP equals MAP minus ICP. Third, know the magic numbers goal, ICP is less than 20, and goal, CPP, is 60 to 70. Fourth, to fix a low CPP, you first try to lower the ICP, and then you raise the MAP. And finally, know Cushing's triad, bradycardia, hypertension with a wide pulse pressure, and irregular respirations means herniation. Neurocritical care can be intimidating, but it's all based on these fundamental principles of pressure and perfusion. If you master these concepts, you will be well prepared for any neuro question the CCRN exam throws at you. Thank you for studying with us. Review these slides, practice your CPP calculations, and good luck on your exam.